Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this particular section, let me discuss the questions related to the rheumatology. So the first question is, we have a 38-year-old woman presenting with morning stiffness lasting 2 hours. And the patient is also having symmetrical swelling of the MCP and PIP joints and fatigue for 3 months. The ESR is 65 millimeters per hour and then the CRP is elevated. Rheumatoid factor is negative, but anti-CCP is strongly positive. Hand ultrasound shows power Doppler signal suggesting synovitis. Which diagnostic interpretation is most accurate? First option, she has seropositive rheumatoid arthritis despite negative rheumatoid factor. Rheumatoid factor must be positive to diagnose rheumatoid arthritis. Anti-CCP positivity alone is insufficient for RA diagnosis. MRI, not ultrasound, is mandatory to diagnose early rheumatoid arthritis. So, she has seropositive rheumatoid arthritis despite the negative rheumatoid factor. So, first option is correct. Why? So, anti-CCP, it is the one which is having the highest specificity, right? Anti-CCP positivity is the one which is having highest specificity. And this anti-CCP, this is present in almost 95 to 98% of rheumatoid arthritis. And patients with anti-CCP positive but rheumatoid factor negative are still considered as the seropositive rheumatoid arthritis, because you take the rheumatoid factor. Rheumatoid factor is not mandatory. 30% of patients, they have seronegative rheumatoid arthritis, right? They have seronegative rheumatoid arthritis. And you take the third option, anti-CCP plus clinical synovitis fulfills. So anti-CCP alone is insufficient for rheumatoid arthritis diagnosis is incorrect. Anti-CCP along with clinical synovitis, that will fulfill the ACR or EULAR criteria for rheumatoid arthritis. And next, MRI improves the sensitivity, but ultrasound is sufficient. Right? MRI improves the sensitivity, but ultrasound is sufficient. So the answer in this question is the first option. Then, a 55-year-old man with long-standing rheumatoid arthritis presents with cough, low-grade fever, and pleuritic chest pain. His RA has been poorly controlled and he is a smoker. Chest X-ray shows peripheral cavity nodules. Rheumatoid factor is very high. Which extra-articular complication is most likely? First option, rheumatoid necrobiotic nodules in the lung, interstitial lung disease, drug-induced pneumonitis from methotrexate, pulmonary embolism from hypercoagulability. So, which extra-articular manifestation is most likely? That is rheumatoid necrobiotic nodules in the lung. So, pulmonary rheumatoid nodules occur in high rheumatoid factor, smoker, and long duration rheumatoid arthritis. So presence of rheumatoid arthritis along with necrobiotic nodules, this is suggestive of what is called as the Kaplan syndrome, right? So cavity, peripheral lung nodules, these are all hallmark features of the Kaplan syndrome. And you take the ILD, that is interstitial lung disease. Interstitial lung disease more often shows reticular or honeycomb changes, right? You will have reticular or honeycomb changes, not the cavity nodules. And methotrexate pneumonitis causes diffuse infiltrates, not cavitations. Pneumonitis from the methotrexate. So with methotrexate, what is that you will notice is you will notice diffuse infiltrates, but you don't have the nodules with the methotrexate. So that's the reason why option C and B is wrong. Then pulmonary embolism from pulmonary embolism does not cause the cavity nodules. So that is the reason why option D is also incorrect. Next question. We have a 48-year-old woman with rheumatoid arthritis. This patient has high disease activity despite maximum tolerated methotrexate for 6 months. She has no latent tuberculosis. Rheumatoid factor and anti-CCP are strongly positive. She also has mild interstitial lung disease, that is non-specific interstitial pattern. ESR and CRP remains high. Which treatment is most appropriate? Next, you need to add a TNF alpha inhibitor, that is adalimumab, switch to rituximab, start leflunomide along with methotrexate, then add hydroxychloroquine and sulfasalazine. So what is the most appropriate therapy next? Like you need to switch to rituximab, right? So rituximab, it is preferred here. Why? Because this particular patient is having, right, this particular patient is having high seropositive rheumatoid arthritis. And this individual is having rheumatoid arthritis plus interstitial lung disease, right? RA with interstitial lung disease. Okay. So why don't you give TNF alpha inhibitor, that is adalimumab? TNF inhibitors, they worsen the rheumatoid arthritis with interstitial lung disease. And this particular patient is already on methotrexate. So methotrexate inadequate responders, we give this rituximab, right? So first option, TNF alpha inhibitors can exacerbate the ILD, so avoid them. And you take third option, start leflunomide along with methotrexate. Leflunomide is also linked with worsening of the interstitial lung disease, so no leflunomide. Then add hydroxychloroquine and sulfasalazine. Triple therapy is less effective in cases of severe form of clinical conditions. So this is less effective in severe form of the interstitial lung disease. So the answer here is what? That is switch to rituximab is the correct statement. Next question. So we have a 27-year-old man presenting with chronic low back pain for 18 months. Pain improves with exercise but not with rest and awakens him in the second half of the night. ESR is 48 millimeters per hour. HLA-B27 is positive. X-ray of the sacroiliac joint is normal, but MRI still shows bilateral bone marrow edema in the sacroiliac joints. What is the most accurate diagnosis? So the options: non-radiographic axial spondyloarthritis, mechanical low back pain, early rheumatoid arthritis involving the spine, then psoriatic arthritis. So this patient is having non-radiographic axial spondyloarthritis because X-ray is like normal, but MRI still shows bilateral bone marrow edema. So what is this? There is a normal X-ray, but MRI is positive, which is showing the presence of the inflammatory changes. HLA-B27 is positive and inflammatory back pain is there. So all these are the points which are suggestive of non-radiographic axial spondyloarthritis, right? And you take the option B. Mechanical pain improves with rest. Okay. So mechanical low back pain. So mechanical pain improves with rest, not with exercise. So option B is wrong. Then third option. Rheumatoid arthritis does not affect the sacroiliac joint in early stages. So that is the reason why your option C is wrong. And next is psoriatic arthritis. No, see, this particular patient, there is no psoriasis and right, or there is no peripheral features of the arthritis, because in psoriatic arthritis, you have the involvement of distal interphalangeal joint and you have the skin manifestation. So this particular patient, there is no psoriasis or peripheral features to support psoriatic arthritis. So your D is also wrong. So the correct answer here is non-radiographic axial spondyloarthritis. Next, fifth question, if you see, a 30-year-old man with known ankylosing spondylitis, they present with acute severe eye pain, photophobia and decreased vision. Examination shows a constricted pupil and the ciliary flush. ESR is high. He denies the trauma. Which extra-articular manifestation best explains his symptom? Acute anterior uveitis, viral conjunctivitis, open angle glaucoma, and then the optic neuritis. So, which extra-articular manifestation best explains this symptom? That is acute anterior uveitis. So, acute anterior uveitis is the most common extra-articular manifestation in ankylosing spondylitis. This acute anterior uveitis, it is observed in almost 25 to 40% of patients. And these patients with acute anterior uveitis, they present with pain, they present with photophobia, they present with blurring of vision, they present with ciliary congestion, and they will have this constricted pupil, that is small pupil will be there. Then you take the viral conjunctivitis. What is the presentation in case of viral conjunctivitis? In viral conjunctivitis, there is presence of the red eye, right? There is presence of red eye, but no photophobia or pupil abnormality, right? There will only be red eye, no photophobia or pupil abnormality. So option B is wrong. Then open angle glaucoma. This open angle glaucoma is incorrect because this will cause a painless vision loss, right? It will cause painless vision loss. And next, optic neuritis is incorrect because optic neuritis, this causes painful eye movements. This causes painful eye movements but no ciliary flush, right? It causes painful eye movement but no ciliary flush. So that is the reason why the correct answer here is A, that is first option. Next, a 34-year-old man with ankylosing spondylitis has persistent inflammatory back pain despite maximum NSAID therapy for 8 weeks. ESR and CRP remains high. HLA-B27 is positive. He has no TB exposure in normal chest X-ray. He refuses frequent injection. Which treatment is the most appropriate? Next. So start interleukin-17 inhibitor, that is secukinumab. Start TNF-alpha inhibitor, that is adalimumab. Add methotrexate. Add sulfasalazine. So the most appropriate therapy next in this patient is you need to start interleukin-17 inhibitor, that is secukinumab. So for axial spondyloarthritis not responding to NSAIDs, the next step is biological therapy. So we have two options in biological therapy. One is secukinumab and the other one is the adalimumab. So TNF-alpha inhibitors and interleukin-17 inhibitors both work, but secukinumab is preferred when the patient prefers less frequent dosing because the patient is saying that he refuses frequent injections. So if you take this secukinumab, this is given monthly. So this is what is the preferred molecule, right? Whereas methotrexate and as well as sulfasalazine do not help the axial symptoms. The methotrexate and as well as sulfasalazine, they are preferable in case of the peripheral arthritis. Right, they are preferable in case of peripheral arthritis. Whereas you take TNF-alpha inhibitor, that is adalimumab, it is effective, but this requires more frequent injections and patient preference is that he want less frequent injections. So that is the reason why interleukin-17 inhibitor secukinumab is a correct statement here. Next question. So we have a 24-year-old man presenting with acute onset asymmetrical oligoarthritis involving the right knee and as well as the left ankle. 1 week earlier, he had dysuria and urethral discharge that resolved spontaneously. Examination shows the enthesitis over the Achilles tendon. Labs ESR is 82 millimeters per hour. The CRP is elevated. HLA-B27 is positive. No crystals on joint aspiration, which is the most likely diagnosis. So this particular patient is having the arthritis, urethritis, and as well as the conjunctivitis, right? So this particular clinical scenario, it is suggestive of the recurrent or reactive arthritis triggered by the chlamydia infection, right? And you take the other options because in case of recurrent or reactive arthritis, you will have a triad. That is arthritis, urethritis, and as well as conjunctivitis. This arthritis, urethritis, and as well as conjunctivitis, this occurs secondary to either sexually transmitted infection or secondary to the gastrointestinal infection. Next is gonococcal arthritis. Gonococcal arthritis, why not this is a correct statement? Gonococcal arthritis, they present with tenosynovitis and they will have the constitutional symptoms. Right, they present with tenosynovitis plus constitutional symptoms, right? Whereas you take psoriatic arthritis. Psoriatic arthritis needs presence of a psoriatic rash for the diagnosis, presence of nail changes to consider psoriatic arthritis. The patient doesn't have, so not. Next is ankylosing spondylitis. Ankylosing spondylitis mainly causes the axial symptoms, right? That is the involvement of the spine and as well as the sacroiliac joint. But these patients with ankylosing spondylitis, they don't cause acute oligoarthritis. They don't cause acute oligoarthritis. So that is the reason why the answer is the reactive arthritis, which is triggered by the chlamydia infection. Next question. We have a 29-year-old male with reactive arthritis, presents with worsening eye redness, photophobia, and blurred vision. He also has hyperkeratotic lesions on the sole of the foot, that is called keratoderma blennorrhagica. ESR and CRP is elevated and there is no history of trauma. Which extra-articular manifestations best explains his current ocular symptoms? So, acute anterior uveitis, viral conjunctivitis, keratitis due to dry eye, and then the optic neuritis. So, the answer in this question is acute anterior uveitis. Reactive arthritis, they cause eye involvement. And how much is the chance of eye involvement in case of the reactive arthritis? The chance of eye involvement in case of reactive arthritis is almost around 30 to 50%. And most commonly it is the acute anterior uveitis, where the patient will have red eye and as well as photophobia, right? Whereas you take conjunctivitis. Why it is incorrect? Because conjunctivitis, it is a milder form and typically it is painless, right? Typically it is painless. But this patient says that there is a painful red eye. So that's why the conjunctivitis gets ruled out. Then you take option C, keratitis due to dry eye. See, keratitis presents with dry eye, but keratitis, it does not present with severe photophobia, right? Keratitis presents with dry eye symptoms, not severe photophobia. So that is the reason why your keratitis due to dry eye is lost. Then next is the optic neuritis. Optic neuritis, they present with painful eye movement. They present with painful eye movement and there is loss of central vision and there is no redness. Right? There is no redness in case of the optic neuritis. So there will be painful eye movement, loss of central vision, and there is no redness. So the answer here is the acute anterior uveitis. Next question. A 33-year-old man with reactive arthritis for 6 weeks presents with persistent knee and ankle synovitis despite NSAIDs and intra-articular steroids. He is HLA-B27 positive, no features of the axial involvement. He denies gastrointestinal or genitourinary symptoms now. TB screening is negative. Which is the most appropriate next line management in this individual? Add sulfasalazine, start methotrexate, start TNF-alpha inhibitor immediately, start prolonged systemic steroids. So, now you see the clinical scenario of this patient. The individual is having the reactive arthritis. So, which is the preferred drug? Sulfasalazine is the preferred DMARD for persistent peripheral arthritis in reactive arthritis. So actually we try to give NSAIDs. If the patient does not respond to the NSAIDs, then we add sulfasalazine, that is a preferred DMARD for persistent peripheral arthritis. And what about methotrexate? Methotrexate can be used, but sulfasalazine, it has stronger evidence for peripheral disease. So that is the reason why here methotrexate is not the correct statement. Then you take the third option. TNF-alpha inhibitors are reserved for refractory disease, right? Immediately is the incorrect statement. They are reserved for refractory disease. So what do you mean by this refractory disease? If the duration of the disease is more than or equal to 3 to 6 months, that is when you give this TNF-alpha inhibitor. Next is start prolonged systemic steroids. See, long-term systemic steroids, they are avoided. Right? Long-term systemic steroids, they are avoided. Why? Due to side effects and as well as lack of sustained benefit. So, start prolonged systemic steroids is a wrong statement because it is associated with the adverse effects. Next question. A 26-year-old woman presenting with the photosensitive rash, oral ulcers, and symmetrical small joint arthritis for 4 months. ESR is high, but CRP is normal. ANA is positive, anti-dsDNA is negative, but anti-Smith antibodies strongly positive C3 and C4 levels are low. Which interpretation is most accurate? So the first option, she fulfills the SLE criteria because anti-Smith is highly specific. Absence of the dsDNA rules out the SLE. Low complement levels exclude the active disease. ESR normality is required for the diagnosis. So this particular patient, she fulfills the SLE criteria because anti-Smith is highly specific, right? So this particular anti-Smith it is having 99% specificity for SLE. It is having 99% specificity for SLE even if dsDNA is negative, right? So even though anti-dsDNA is negative, anti-Smith antibody, it has 99% specificity for the SLE. And along with that, there is low C3 and as well as C4. It supports the immune complex disease activity. And you take the second option. dsDNA negativity does not rule out the disease. So absence of the dsDNA rules out disease, wrong statement. And why third option is incorrect? CRP often remains normal despite active SLE. Okay. So low complement levels exclude the active disease. In CRP often remains normal even though the disease is active. So this patient, if you take the CRP is normal. So CRP remains normal despite active SLE. So therefore, she fulfills the ULR or the ACR SLE classification with high ANA, anti-Smith and as well as the clinical signs. And ESR normality is required for the diagnosis? No. Right? So ESR, it is usually elevated in these individuals. So the correct answer here is she fulfills the SLE criteria because anti-Smith is highly specific. Next question. So we have a 21-year-old girl with SLE presenting with the edema, hypertension and as well as the frothy urine. Lab shows the serum creatinine of 1.8 milligrams per deciliter, urine protein 4.5 grams per day, RBC cast, low C3, C4, high anti-dsDNA titers. Kidney biopsy show endocapillary hypercellularity and subendothelial immune deposits, that is full house effect. Which class of lupus nephritis is this particular patient presenting to? Class 4, class 2, class 5 and class 1 lupus nephritis. So this particular patient is in class 4 diffuse lupus nephritis because this patient is having, like the picture, nephritic, rising creatinine. Why are you saying like nephritic? Because RBC and RBC cast is there. And subendothelial deposits, all these, they strongly suggest it is a class 4 lupus nephritis. And this class 4 lupus nephritis, it is the most severe and common cause of renal failure in the SLE. Right? So this is the most severe form. Whereas you take the class 5. Class 5 presents mainly with nephrotic range proteinuria without active urinary sediment. Because if you see this particular question, urine protein 4.5 nephrotic range, RBC cast. So class 5, the individual will not have any active urinary sediment. So class 5 is ruled out. What about class 1 and class 2? Class 1 and class 2, they do not cause significant proteinuria or renal failure. So that is the reason why your B and D is also ruled out. So the correct answer is A, that is class 4 lupus nephritis. Next question. We have a 32-year-old woman with the SLE presenting with seizures, malar rash, alopecia, anemia, thrombocytopenia and rising creatinine with RBC cast. C3, C4 levels are markedly low. The dsDNA is very high. She is febrile but cultures are negative. What is the most appropriate immediate treatment in this particular patient? So the options are high dose IV methylprednisolone followed by cyclophosphamide, hydroxychloroquine alone, belimumab as the first line therapy, and the fourth option, prednisolone low dose plus methotrexate. So here the most appropriate immediate treatment is the high dose intravenous methylprednisolone followed by that cyclophosphamide. See, this is life-threatening severe SLE. Why? Because there is like neurological involvement in this individual. Life-threatening severe SLE with neurological involvement. And this particular patient is also having, seizures are telling you that the individual is having like neurological involvement. And there is rising creatinine. So rising creatinine tells that there is renal failure in this individual. And there is also cytopenia. So these tells that the patient is having life-threatening severe SLE. So what is that we start with? We start with the induction therapy. So in the induction therapy, we give IV methylprednisolone, which is a steroid. Followed by that, we give cyclophosphamide or mycophenolate. So that is what is the induction therapy what we give in a life-threatening severe SLE patients. Next is hydroxychloroquine. Why not? It's being correct. Hydroxychloroquine is mandatory long-term, but inadequate as monotherapy here. So you cannot give in this severe cases as monotherapy. Next is belimumab. Belimumab is not used in acute severe organ threatening flares, right? It is not given in acute severe organ threatening flares. Next is the methotrexate. So methotrexate is only for mild to moderate musculoskeletal disease. It cannot be given in case of the severe form of the SLE. So the correct statement here is what? That is high dose IV methylprednisolone followed by that cyclophosphamide. Next question. So we have a 46-year-old woman presenting with progressive dry eyes, gritty sensation, and difficulty in swallowing dry food for 8 months. Shimmer's test is positive, ANA is positive, anti-ROR SSA is strongly positive, anti-LOR SSB mildly positive, parotid ultrasound shows hypoechoic areas with heterogeneity. Which is the most accurate diagnosis? Primary Sjogren's, secondary Sjogren's due to rheumatoid arthritis, sarcoidosis with lacrimal gland involvement, drug-induced Sicca syndrome. So this patient is having the primary Sjogren's syndrome, right? So anti-RO or SSA positivity, Shimmer's test, and salivary gland involvement. These three are very much classical for the primary Sjogren's. Whereas you take secondary Sjogren's. Secondary Sjogren's require an underlying connective tissue disorder. That means along with Sjogren's, there should be an underlying connective tissue disorder, which is absent here. So that is the reason why secondary Sjogren's is ruled out. And you take sarcoidosis. Sarcoidosis causes lacrimal gland enlargement, but does not have the SSA and as well as SSB positivity. So that is the reason why your sarcoidosis is ruled out. And drug-induced Sicca syndrome. Drug-induced Sicca, it lacks the serology and parotid gland ultrasound abnormalities. So in drug-induced Sicca, antibodies will not be positive and the parotid gland ultrasound abnormalities will not be there. So that's how you will rule out the option D as well. Next question. So we have a 52-year-old woman with known Sjogren's, reports fatigue, new onset palpable purpura on the legs, worsening peripheral neuropathy. Labs show low C4, positive rheumatoid factor, elevated cryoglobulins, urine analysis show mild proteinuria. Which systemic complication has best explains her current presentation? First option, cryoglobulinic vasculitis. Second option, small fiber neuropathy due to diabetes. Third option, allergic vasculitis. Fourth option, drug hypersensitivity rash. So her current presentation is with cryoglobulinic vasculitis. So this patient is having palpable purpura, low complement levels, rheumatoid factor positivity is there, and there is also cryoglobulins which are being present. So all these four, palpable purpura, low complement, RA factor positivity, cryoglobulins, these are all classical for a cryoglobulinic vasculitis in case of Sjogren's, right? And associated with peripheral neuropathy and mild renal involvement. And you take diabetic neuropathy does not cause purpura or low complement. So you take this diabetes, second option, diabetic neuropathy does not cause purpura and you will not have low complement. So option B ruled out. Then allergic and drug hypersensitivity. Allergic or drug vasculitis lacks cryoglobulins. You don't have cryoglobulins in allergic or drug vasculitis, right? And allergic or drug vasculitis lacks complement consumption. So no cryoglobulins, no complement consumption in case of allergic or drug vasculitis. So the answer in this question is the cryoglobulinic vasculitis. Next question. So we have a 55-year-old woman with primary Sjogren's develops interstitial lung disease, that is non-specific interstitial pneumonitis pattern, and severe parotid gland enlargement. She also has recurrent vasculitic skin lesions despite hydroxychloroquine and symptomatic tear or saliva substitutes. TB screening is negative. TB screening is negative. Which treatment is most appropriate next? The options are rituximab, pilocarpine, methotrexate alone, low dose prednisolone only. So which treatment is most appropriate next? That is rituximab. This rituximab, it is recommended in Sjogren's. But when is it recommended? Along with Sjogren's syndrome, if the patient also has systemic manifestations, right? If the patient also has systemic manifestations like interstitial lung disease, vasculitis, parotid swelling, neuropathy, if these are there, then rituximab is being recommended. And you take this pilocarpine. Pilocarpine only treats the Zika symptoms, but this patient is also having systemic symptoms. So that is the reason why pilocarpine alone is not sufficient. Next is methotrexate. Methotrexate is useful for mild arthritis, but not for vasculitis, not for interstitial lung disease. Methotrexate is useful for mild arthritis, but not for vasculitis or ILD. So your option C is also wrong. Low dose prednisolone. Low dose steroids alone are inadequate for organ threatening disease. So whenever there is an organ threatening disease, definitely you require this particular rituximab in this particular clinical conditions of Sjogren's. So this is the question number 15. So the next question is, we have a 42-year-old woman presenting with Raynaud's phenomena, digital pitting scars, and there is tight skin up to elbows, and there is also dysphagia. She develops progressive breathlessness, and HRCT shows basilar ground glass opacities with early fibrosis. ANA is positive with the ratio of 1:640. Anti-SCL70 with the anti-topoisomerase 1 antibody is strongly positive. Which diagnosis is most consistent with this clinical and as well as the serological pattern? So the first option, diffuse cutaneous systemic sclerosis with ILD involvement, limited cutaneous systemic sclerosis, that is CREST syndrome, then mixed connective tissue disease, then Sjogren's syndrome with Raynaud's. So here the correct answer is the diffuse cutaneous systemic sclerosis with the interstitial lung disease. Now let me discuss the correct option and as well as incorrect options. Diffuse systemic sclerosis, there will be like proximal skin involvement and early visceral organ involvement will be there in case of the diffuse systemic sclerosis. And the anti-SCL70 strongly associated with the interstitial lung disease, right? Strongly associated with interstitial lung disease. Whereas you take this limited systemic sclerosis. Limited systemic sclerosis, this has anti-centromere antibody being positive, right? So this patient, okay, so this patient has the anti-centromere antibody being positive and pulmonary hypertension will be there. But in case of the limited cutaneous systemic sclerosis, presence of ILD is not the feature, right? ILD is not early in case of limited systemic sclerosis. Next is mixed connective tissue disease. Mixed connective tissue disease, the antibody that you have is anti-U1-RNP, right? So anti-U1-RNP will be the antibody in mixed connective tissue disease. And you take the Sjogren's. Sjogren's does not cause skin thickening. So in that way, the Sjogren's has been ruled out. So the correct answer is diffuse cutaneous systemic sclerosis with ILD involvement. Next question. We have a 51-year-old woman with diffuse systemic sclerosis presenting with sudden severe headache. Blood pressure is 190 by 110 millimeters of mercury, acute dyspnea and rising creatinine from 0.8 to 2.3 milligram per deciliter over 48 hours. Platelets, they are mildly low. Schistocytes are present on the peripheral smear. LDH is elevated and she is not on the ACE inhibitors. What is the most likely diagnosis? So the options are the scleroderma renal crisis, ANCA associated vasculitis, acute tubular necrosis and the lupus nephritis flare. So this patient is having the scleroderma renal crisis. So you see the presentation, acute severe hypertension, rapidly rising creatinine, microangiopathic hemolysis, All these are very much classical in case of the scleroderma renal crisis. So how is that you are telling like there is a microangiopathic hemolysis? Because there are schistocytes on the peripheral smear, right? So this is like most commonly seen in diffuse systemic scleroderma, especially early disease or the steroid exposure. And you take the other options. ANCA vasculitis causes hematuria with different serology, right? The serology in case of the ANCA associated vasculitis, it is not the same like what we see in case of the systemic scleroderma. And in case of ANCA associated vasculitis, you don't have this particular renal crisis picture commonly. Next, acute tubular necrosis. Acute tubular necrosis does not cause malignant hypertension. So that is ruled out. Next is you take the fourth option. Lupus nephritis requires the SLE serology. But this particular patient is not having any SLE serology. So that will rule out the SLE. What is that SLE serology? That is anti-nuclear antibody and as well as anti-DS DNA. So that should be there. But that is not there. So that will rule out the lupus nephritis. Next question. So we have a 49-year-old woman with systemic sclerosis presents with the progressive dyspnea and the HRCT showing fibrotic non-specific interstitial pneumonitis pattern. Pulmonary function test reveal the forced vital capacity 58% predicted and DLCO 40%. She is ANA positive and anti-SCL70 positive. No features of pulmonary hypertension. Symptoms persist despite low dose prednisolone. Which treatment is most appropriate in this patient? The options are mycophenolate mofetil as the first line therapy for systemic sclerosis interstitial lung disease, high dose steroids, methotrexate as the first line agent, and then the anticoagulant therapy. So like what is most appropriate in this particular patient is the mycophenolate mofetil. So mycophenolate mofetil, this is the first line for systemic sclerosis associated ILD, because this particular patient is having the systemic sclerosis, that is no doubt, and there is also ILD. So for systemic sclerosis associated ILD, mycophenolate mofetil is the first line drug, right? Whereas you take the second option, that is high dose steroids. High dose steroids increases the risk of scleroderma renal crisis. That is the reason why that should be avoided. Next, methotrexate as the first line agent. Methotrexate, it helps skin disease, right? Methotrexate, it helps the skin disease, right? But not the interstitial lung disease. Next is the anticoagulation. Anticoagulation has no role unless the pulmonary hypertension with thromboembolic disease. So in this particular scenario, there is no role of anticoagulation therapy. Only in case of pulmonary thromboembolism causing pulmonary hypertension, anticoagulation is what to be given. So the correct answer is mycophenolate mofetil as the first line therapy for systemic sclerosis induced interstitial lung disease. And you take the next question. So we have a 32-year-old man from the Middle East presenting with recurrent painful oral ulcers for 3 years. He also reports episodic genital ulcers and painful red eye with blurred vision. Skin prick test shows an exaggerated pustular response after 24 hours. ESR is elevated, ANA and rheumatoid factors are negative, which is the most likely diagnosis. Behçet syndrome, reactive arthritis, herpetic stomatitis, Crohn's disease with extraintestinal lesion. So the most likely diagnosis in this patient is the Behçet syndrome. So in patients with Behçet's, they will have recurrent oral ulcers. They will have genital ulcers. They may have uveitis. And the pathology test will be positive. So there will be positive pathology test. So all these recurrent oral ulcers, genital ulcers, uveitis and positive pathology, they are all classical for the Behçet's, right? Whereas you take this reactive arthritis. Reactive arthritis, you have a triad. What is that? Urethritis, arthritis and as well as conjunctivitis, right? But in case of reactive arthritis, there is no recurrent ulcers, right? There is no recurrent ulcers. So reactive arthritis is ruled out. Next is herpetic lesions. Herpetic lesions, they are not recurrent oral or genital aphthous ulcers, right? The herpetic lesions, they are not recurrent oral or genital aphthous ulcers with uveitis. Next is, it is not Crohn's. So Crohn's, they may have oral ulcers, but pathology test and uveitis strongly point towards the Behçet's but not the Crohn's disease, right? they may have these oral ulcers, Crohn's, but your pathology test will not be positive in case of Crohn's. So that is the reason why the answer is the Behçet syndrome. Next question. So we have a 28-year-old man with known Behçet syndrome or Behçet's presenting with sudden pleuritic chest pain and hemoptysis. He has the history of recurrent leg ulcers and posterior uveitis. CT pulmonary angiography shows a large pulmonary artery aneurysm with surrounding inflammatory changes. ESR and CRP, they are markedly elevated. Which clinical feature of Behçet's best explains this complication? First option, necrotizing vasculitis involving both arteries and veins. Second, hypercoagulable state due to antiphospholipid antibodies. Third, granulomatous inflammation similar to GPA. Fourth, immune complex deposition causing small vessel vasculitis only. So this patient, the clinical features are secondary to necrotizing vasculitis involving both arteries and as well as veins. So Behçet's, this is one of the few diseases causing both arterial and as well as venous vasculitis, right? Both arterial and as well as the venous vasculitis is observed in case of Behçet's, and that leads to the pulmonary artery aneurysm, right? That leads to pulmonary artery aneurysm, which is a life-threatening complication. And you take the antiphospholipid antibodies. Antiphospholipid syndrome is not the feature of the Behçet's. It is not the feature of the Behçet's, right? And granulomatous inflammation. Remember, granulomatous inflammation is observed in case of granulomatosis with polyangiitis, that is Wegener's, but not in case of Behçet's. Behçet's is not the granulomatous vasculitis, right? Next, immune complex deposition called small vessel vasculitis only. Remember, in case of Behçet's, you have both the medium and as well as the large vessel vasculitis, and along with that small vessel vasculitis. It is not only small vessel vasculitis. So the answer here is necrotizing vasculitis involving both arteries and as well as veins. Next question. So we have a 30-year-old man with Behçet syndrome presenting with severe posterior uveitis and retinal vasculitis. He is losing vision despite topical steroids. He has no latent tuberculosis and normal liver function tests. And NSAIDs have provided no relief. Which is the most appropriate next step in the management of this patient? Start high-dose systemic steroids plus azathioprine or anti-TNF therapy. Give long-term colchicine alone. Start methotrexate monotherapy. Begin hydroxychloroquine therapy. So this particular patient should be given high-dose systemic steroids plus azathioprine or anti-TNF therapy should be given, right? So this individual is like having sight-threatening, right? That is vision-threatening ocular Behçet's. So they require the systemic steroids plus steroid-sparing immunosuppressants. What are those steroid-sparing immunosuppressants? That is azathioprine, next cyclophosphamide, or anti-TNF like infliximab, right? Anti-TNF like infliximab. And what about the colchicine? Colchicine is mainly for mucocutaneous and arthritic disease. This colchicine is not for ocular disease. So option B ruled out. And methotrexate. Methotrexate has limited benefit for refractory ocular Behçet's. Okay, it has the limited benefit. Hydroxychloroquine. Hydroxychloroquine is not primary drug in case of the Behçet's management. So option D is also ruled out. So correct answer is, so you need to start like steroid sparing systemic steroids plus steroid sparing immunosuppressants. That should be started in this patient. Next question. So we have a 71-year-old woman presenting with new onset headache, jaw pain while chewing, and scalp tenderness. ESR is 92 millimeters per hour and CRP is high. She reports sudden blurring of vision in the right eye. Temporal artery is tender and nodular. Duplex ultrasound shows a halo sign. What is the most accurate next step? First option, start high-dose steroids immediately even before the biopsy. Wait for temporal artery biopsy report before starting the treatment. Start methotrexate as the first-line therapy. Order PET-CT before the treatment initiation. So you need to start high dose steroids immediately, even before biopsy. What exactly is the diagnosis here? It is temporal arteritis or giant cell arteritis. So giant cell arteritis with visual symptoms, right? This particular individual is having like blurred vision in the right eye. So giant cell arteritis with visual symptoms is a medical emergency. So treatment must begin immediately to prevent the permanent vision loss. And biopsy, right? And you take the second option. Biopsy should follow within 1 to 2 weeks, but never delay the steroids. Okay. So wait for temporal artery biopsy before starting the treatment. So biopsy should follow within 1 to 2 weeks, but never delay the steroids. Next. So option B wrong. So next, methotrexate. Methotrexate is a steroid sparing. This is not first line in acute visual threatening diseases. So start methotrexate as first line, wrong. It is steroid first. Next, PET-CT. So PET-CT will assess large vessel involvement, but for PET-CT, you should not delay the therapy. So that is the reason why option D is wrong. So first option is correct. Next question. So we have a 24-year-old woman presenting with exertional arm fatigue and dizziness. Examination reveals absent left radial pulse and blood pressure difference of more than 20 millimeters of mercury between the arms. There is a bruit over the subclavian artery and ESR is 70 millimeters per hour. CT angiography shows concentric wall thickening of the aortic arch branches. Which diagnosis is most consistent with the finding of this patient? Takayasu arteritis, polyarteritis nodosa, thoracic outlet syndrome, atherosclerotic occlusive disease. So the most consistent with the finding is the Takayasu arteritis. So this patient is a young woman, pulseless limb. There is a discrepancy in the blood pressure and there is also vessel wall thickening. All these point towards the Takayasu arteritis. All these point towards Takayasu arteritis. Okay. And you take the PAN. Polyarteritis nodosa, it is usually disease of medium vessel vasculitis, but it does not cause the pulse deficit. It does not cause the pulse deficit. Thoracic outlet syndrome. Thoracic outlet syndrome may mimic arm ischemia, but does not cause high ESR or aortic wall inflammation. So high ESR is not the feature of your thoracic outlet syndrome. So option C wrong. Next, atherosclerosis. Atherosclerosis rarely affects young adult females, right? It rarely affects young adult females and lacks systemic inflammation. Okay. So option D is wrong, right? Atherosclerosis, it rarely affects the young adult females and it lacks systemic inflammation. Next question. We have a 62-year-old man with recently diagnosed giant cell arteritis, improved on high dose steroids but relapses during tapering. ESR and CRP is rise again and he reports returning jaw claudication. He has diabetes and cannot tolerate the prolongation with steroids. Cannot tolerate prolonged high steroids. Which treatment is most appropriate to prevent further relapse in this patient? Tocilizumab, cyclophosphamide, azathioprine as monotherapy, low dose aspirin only. So what we give here is tocilizumab. See, this tocilizumab, which is an interleukin 6 receptor inhibitor, that is the preferred steroid sparing agent, right? That is a preferred steroid sparing agent in relapsing or steroid intolerant giant cell arteritis. Okay, in case of relapsing or steroid intolerant giant cell arteritis, tocilizumab is the preferred steroid sparing agent. Coming to cyclophosphamide. Cyclophosphamide, it is for severe vasculitis, right? It is for severe vasculitis like ANCA. That is not first line in case of giant cell arteritis. So cyclophosphamide out. Azathioprine is less effective than compared to that of tocilizumab. And aspirin reduces ischemic complications but does not prevent the relapse. So that is the reason why option D is gone, right? It will reduce the ischemic complications but does not prevent the relapse. So the answer is tocilizumab. So next question. So we have a 46-year-old man presenting with fever, weight loss, severe myalgias and hypertension. He reports abdominal pain after meals and testicular tenderness. Labs show ESR 92 millimeters per hour. Renal function is normal. Hepatitis B surface antigen is positive. Nerve conduction study shows mononeuritis multiplex. ANCA is negative. Which diagnosis is most consistent with this presentation? PAN, microscopic polyangiitis, Takayasu arthritis, and then the Goodpasture syndrome. So, the answer in this question is polyarthritis nodosa. So, this patient, if you observe, like having a association with hepatitis B, this tells it is PAN. So, medium vessel necrotizing vasculitis with HBV association, mononeuritis multiplex, abdominal angina where the patient is having pain after having meals, testicular pain, ANCA negative profile, all these points towards polyarthritis nodosa. Whereas microscopic polyangiitis, you have P ANCA being positive. So that is gone. Next, Takayasu arthritis. It mainly affects the aorta and as well as large vessel. Next is the Goodpasture syndrome. Goodpasture syndrome, this will cause the pulmonary hemorrhage plus glomerulonephritis. Right? So this causes pulmonary hemorrhage and glomerulonephritis. But in Goodpasture syndrome, you don't have the mesenteric ischemia or neuropathy. So in that way, the Goodpasture syndrome is ruled out. Next question. We have a 7-year-old child presenting with 6 days of high fever, strawberry gums, conjunctival injection, edema of the hands and feet, and there is a polymorphous rash. And there is also cervical lymphadenopathy being present. Labs show thrombocytosis and elevated CRP. Echocardiography reveals a 5 mm dilatation of the left coronary artery. Which complication is most characteristic in this patient? So, coronary artery aneurysm formation, restrictive cardiomyopathy, aortic regurgitation due to root dilatation, and then cardiac tamponade. So, this patient is at risk of development of coronary artery aneurysm. So, what is this disease? It is Kawasaki disease. So, Kawasaki disease, it is a classic medium vessel vasculitis in children leading to coronary artery aneurysm. So, aneurysm form in almost, right, aneurysms they form in almost 20 to 25% if untreated, right, aneurysms form in 20 to 25% if untreated, right. Next, restrictive cardiomyopathy and as well as your cardiac tamponade, they are uncommon in patients with the Kawasaki disease. Next, aortic regurgitation. Aortic regurgitation is seen in large vessel vasculitis. And what is that large vessel vasculitis? That is Takayasu arthritis, but not in case of Kawasaki. So the answer here is the coronary artery aneurysm formation is the correct statement or the diagnosis, or I mean to say the complication. Next, we have a 52-year-old man with confirmed polyarthritis nodosa, presents with severe abdominal pain, libido reticularis, and progressive neuropathy. Repeat CT angiography shows microaneurysm of the mesenteric arteries and he is HBV negative. Kidney function remains normal. His symptoms are worsening despite moderate dose steroids. Which treatment is most appropriate next? Right? Which treatment is most appropriate next? So the answer is add cyclophosphamide for induction therapy, add rituximab as the first line agent, replace steroids with methotrexate monotherapy, begin plasmapheresis immediately. So this patient you need to add cyclophosphamide. This patient you need to add cyclophosphamide. Why? See, there is like severe organ threatening polyarthritis nodosa. How are you telling that it is an organ threatening? Because the patient is having microaneurysm of the mesenteric arteries. So there is mesenteric ischemia. Along with that there is neuropathy. So severe organ threatening PAN, they require high dose steroids. They require the high dose steroids and cyclophosphamide. So this particular patient need to be added with cyclophosphamide for remission induction. Next is rituximab, second option. Rituximab is preferred in ANCA vasculitis. Okay, it is the first agent in case of ANCA vasculitis, but not in case of PAN. Next, you take the third option. Methotrexate is inadequate for serious visceral involvement. Methotrexate monotherapy is not for serious visceral involvement. Next, plasmapheresis. Plasmapheresis is used, right? Plasmapheresis is used mainly for HBV associated PAN. Right, for HBV associated PAN, right, plasmapheresis is used there, but not needed here. So the answer here is you need to add cyclophosphamide for induction therapy here. Next question. We have a 42-year-old man presenting with chronic sinusitis. There is also recurrent epistaxis, cough, and hemoptysis. Urine analysis show RBC cast and proteinuria. Chest CT shows bilateral cavitary nodules. ESR or CRP are markedly elevated. Serology shows C ANCA strongly positive and proteinase 3 ANCA 1:160. Which is the most likely diagnosis? The options are granulomatosis with polyangiitis, microscopic polyangiitis, Church-Strauss syndrome, and then the Good-Pasteur's disease. So the answer here is granulomatosis with polyangiitis. So why it is granulomatosis with polyangiitis? Because it is characterized by a triad like upper respiratory ENT involvement, lung cavitary nodules, and then rapidly progressive glomerulonephritis. All these, they strongly suggest proteinase 3, all these they suggest vaginous granulomatosis where you have the C ANCA being positive. So C ANCA among all these options, it is present only in granulomatosis with polyangiitis. And you take microscopic polyangiitis, they cause pulmonary hemorrhage but no granuloma, no cavitary nodules in case of microscopic polyangiitis. Then eosinophilic granulomatosis with polyangiitis, they require asthma or eosinophilia but it is absent here. So option C gone. Next is Good-Pasteur's. Good-Pasteur's, they cause lung hemorrhage plus glomerulonephritis, right? So Good-Pasteur's, they present with what? Lung hemorrhage and glomerulonephritis without ENT involvement. So that is the reason why the answer is here Wegener's, which is nothing but granulomatosis with polyangiitis. So next question. A 19-year-old male presenting with palpable purpura on lower limbs, abdominal pain and arthralgia. He also has new onset hematuria and mild proteinuria. Complement levels are normal. Renal biopsy shows mesangial IgA deposition. Which of the following features most strongly supports this diagnosis? First option, palpable purpura with abdominal pain in a young adult. Second option, low complement levels. Third option, C ANCA positivity. Fourth option, pulmonary hemorrhage with nodular lesions. So here the answer is the palpable purpura with abdominal pain in a young adult. So what does this clinical picture suggest you of? It is suggestive of Henoch-Schönlein's purpura, which is nothing but IgA vasculitis, right? Which is nothing but IgA vasculitis. So IgA vasculitis, they present with lower limb purpura, they present with abdominal pain, they present with arthritis, they present with IgA nephritis. Whereas in patients with the Henoch-Schönlein's purpura, the complement levels, they remain normal. Complement levels, they remain normal. So if at all, if there is low complement is present in case of the lupus vasculitis, right? It is present in case of lupus vasculitis and it is also present in case of the cryoglobulinemia, right? But here the complement levels are normal, that will rule out your low complement levels. And that in a sense, like in patients with Henoch-Schönlein's purpura, the complement levels will remain normal. Next, C ANCA positivity, that is present in case of Wegener's. And pulmonary hemorrhage with nodular lesions. So pulmonary hemorrhage with nodular lesions, it goes mainly towards granulomatosis with polyangiitis, that is Wegener's, but not in case of IgA vasculitis. So the answer here is first option. So the last question, we have a 55-year-old man presenting with rapidly rising creatinine, hematuria and pulmonary hemorrhage and alveolar infiltrates on CT. P ANCA or myeloperoxidase is positive. Hemoglobin drops to 7.8 due to the pulmonary bleeding. He is hemodynamically stable. Which is the most appropriate immediate treatment in this individual? IV methylprednisolone plus rituximab or cyclophosphamide, plasma exchange alone, methotrexate plus low-dose steroids, and azathioprine as the induction therapy. So the correct answer here is IV methylprednisolone plus rituximab or cyclophosphamide. So like this picture, it is severe ANCA vasculitis with pulmonary renal syndrome. These patients, they require immediate induction therapy, and that immediate induction therapy is pulse IV steroids plus cyclophosphamide or rituximab should be given. And plasma exchange not routinely indicated unless if the patient is having, so when is this plasma exchange done? If the individual is having life-threatening diffuse alveolar hemorrhage, right? Or if the creatinine is like more than 5 or 7, that is when plasma exchange is required. Whereas methotrexate and azathioprine, they are all maintenance drugs. They are not given for the induction. So the answer here is IV methylprednisolone plus rituximab or cyclophosphamide. So this completes the discussion of these important questions in the rheumatology. Thank you very much.